Usually when we hear the term heart failure, it sounds so absolute, like a sudden fatal stop.
Yeah, it has this terrifying finality to the phrase, right?
Exactly.
Yeah.
You picture an engine just seizing up, smoking on the side of the highway, and the car is completely dead. Welcome to today's deep dive, by the way.
Glad to be here. And yeah, people naturally assume heart failure means the heart has simply stopped working entirely, or like a cardiac arrest is happening in real time.
But today we are diving into this incredibly detailed set of medical notes by Dr. Asafilla. And these notes synthesize the updated 2022 to 2025 concepts from the major cardiology societies, the ACC, the AHA, the ESC.
The big hitters in the field.
Right. And what becomes immediately apparent in these guidelines is that heart failure isn't a sudden stop at all. It's a complex, ongoing clinical syndrome. It is essentially a highly nuanced mechanical and plumbing issue.
The modern medical definition has completely shifted away from that blanket term for a dying heart concept. Today, it's characterized by very specific symptoms and signs caused by structural or functional abnormalities.
And doctors need proof now, right? They can't just guess based on symptoms.
Exactly. To formally make the diagnosis, physicians need objective confirmation. They're looking for elevated biomarkers in the blood or clear evidence of cardiac congestion either at rest or during stress.
So we're really talking about a quantifiable decline in the organ's efficiency over a long timeline.
Yes. When you strip away all the dense medical terminology, the underlying mechanics basically boil down to two main failures.
Okay, let's break those down.
It's either a supply problem, which is inadequate cardiac output where the pump just isn't pushing enough blood forward, or it's a pressure problem, meaning elevated intracardiac filling pressures.
So the pump might still be pushing some blood out,
Yeah.
but the pressure inside the heart is dangerously high, just trying to fill the chamber back up.
Right. And quite often, both of those things are happening simultaneously. If the forward flow is too low, the systemic circulation basically starves for oxygen.
Like the kidneys, the brain, the muscles.
Exactly. They all suffer from hypoperfusion. On the flip side, if the backward pressure is too high, fluid leaks out of the vascular space into the lungs and tissues. The body effectively drowns in its own fluid.
It's just wild to think about.
It is, and understanding those two distinct mechanical failures, the forward starvation and the backward congestion, that is the entire foundation for how the field categorizes and treats the disease.
Okay, let's unpack how they actually categorize this pump failure. Because they don't just say, oh, you have heart failure and leave it at that. They measure the efficiency of the engine using ejection fraction, or EF.
Right, the EF. They are looking at what percentage of the blood in the left ventricle actually gets squeezed out with each single beat.
And historically, the whole treatment paradigm was split into two main camps based on that math, right?
Yeah, mainly two camps. First, there is HFrEF, or heart failure with reduced ejection fraction. This is the classic, weak, floppy, dilated heart. The ejection fraction drops to 40% or lower.
So it's basically systolic dysfunction. The muscle is just too weak to contract forcefully.
Precisely. But then on the other end of the spectrum, we have HFpEF, heart failure with preserved ejection fraction.
And this is where the ejection fraction is 50% or higher.
Right. The pump is still squeezing out a normal percentage of blood, which sounds perfectly fine until you actually look at the architecture of the heart.
Because this is diastolic dysfunction.
Exactly. The heart muscle has become profoundly thick and stiff. So even though it's squeezing out 50% of what's inside it, the actual physical volume of the chamber is tiny.
Because the stiff walls literally can't relax to fill properly in the first place.
You got it. And there's also a middle ground category called HFmrEF, mildly reduced ejection fraction, sitting in that gray zone between 41 and 49%.
But I want to focus on that preserved category for a second, HFpEF, because a major paradigm shift in these new guidelines is how we view that specific category. For a very long time, there was this clinical bias that because the ejection fraction was normal, HFpEF couldn't be that bad.
Oh, absolutely. It was viewed as the milder version of the disease for decades.
But the new guidelines completely shatter that illusion. HFpEF now accounts for roughly 50% of all heart failure cases.
It is absolutely no longer considered a benign condition. The mortality rate approaches that of HFrEF. The hospitalization rates are just as bad.
Wow. So a thick, stiff heart is proving to be just as deadly as a weak, dilated heart.
It is a massive public health crisis, and largely because HFpEF is driven by systemic metabolic issues that are incredibly difficult to reverse. But alongside that grim reality, the updated guidelines formalize a brand new, highly specific category.
Oh, right, HFpEF.
Yes, heart failure with improved ejection fraction.
So this applies to patients who were originally in the danger zone, right? Like an ejection fraction of 40% or lower. But thanks to intensive treatment, they've improved to over 40%.
With at least a 10% absolute increase from their baseline, yes. That is the crucial metric for this new category.
But the clinical challenge here is managing patient psychology, isn't it? And honestly, sometimes physician psychology.
Oh, 100%. What's fascinating here is that when a patient sees their numbers go up into a normal or mild range, the immediate impulse is to assume they are cured.
Right, they want to stop the medications, toss the beta blockers, stop the diuretics. But think of HFpEF like a leaky, failing boat engine that you've temporarily patched up with heavy-duty duct tape.
That is a perfect way to look at it.
Yeah, like, yes, the engine is running better, the boat is moving across the water without sinking, But just because the engine sounds better doesn't mean the crack in the metal is gone. If you peel that duct tape off, you're going straight to the bottom of the lake.
That is the exact clinical reality outlined in Dr. Isafola's notes. The guidelines specifically mandate that improvement does not equal cure.
So the meds stay on.
Lifelong. Patients whose ejection fraction improves must continue their guideline-directed medical therapy, or GDMT, forever. The foundational architecture of their heart is still fundamentally altered.
And if they stop.
Relapse is incredibly common and often more severe than the initial presentation. The duct tape stays on permanently.
That distinction between fixing the math and fixing the underlying architecture is a perfect bridge to how this condition actually progresses over time.
Right, the timeline of trouble.
Because there is a fundamental difference between how the heart looks structurally on a scan and how you actually feel on a Tuesday afternoon. We have two parallel systems here, the ACC and AHA stages and the NYHA classification.
Distinguishing between these two is critical. The ACA stages describe the structural progression. It is a one-way timeline of physical damage.
So stage A is just categorized as being at risk, right?
Exactly. There's no structural disease yet and no symptoms. But the biological cascade has started. This includes people with hypertension, diabetes, obesity, or patients who've had cardiotoxic chemotherapy.
I mean, millions of people are walking around in stage A. Their heart looks completely fine on an ultrasound, but the systemic environment is already laying the groundwork for cellular damage.
Then we move to stage B, which is pre-heart failure. Now there is visible structural damage.
Like a silent heart attack or a thickened muscle from high blood pressure.
Right. But the patient still has absolutely zero symptoms. They feel totally fine.
And then stage C is structural disease combined with current or prior symptoms.
Mm.
The pump is damaged and the body is feeling it.
Yes. And finally, stage D is advanced heart failure requiring specialized therapies. Things like continuous IV inotropes, a mechanical pump like an LVAD, or a full heart transplant.
Okay, so that's the structural side. But parallel to that is the New York Heart Association, or NYHA, functional classification. And this measures how the patient actually functions in their daily life.
Class I means no limitations. Class 2 means symptoms with ordinary activity.
Like shortness of breath when climbing a flight of stairs.
Exactly. Class 3 is symptoms with less than ordinary activity, like just walking from the living room to the kitchen. And Class 4 is severe, experiencing symptoms even while resting in a chair.
Wait, let me push back on this to clarify how these two systems interact for the listener. Because if the structural stages are a one-way street, but the functional classes measure how you feel, can a patient be a stage C in the ACC system because their heart has permanent structural damage, but simultaneously be a class I in the NYHA system because today they feel fine?
Absolutely. If we connect this to the bigger picture, that is a fundamental concept in modern management.
Because the stages don't go backwards.
Right. Once you have a dead portion of heart muscle from a heart attack, you cannot go backward from stage C to stage B. That tissue is scarred permanently.
But the functional class can fluctuate.
Highly dynamic. If a stage C patient gets put on the optimal guideline-directed medical therapy, they can go from being breathless on the stairs in class 2 back to feeling completely normal in class 1. Their daily function improves dramatically.
It's the difference between the structural integrity of a house and how comfortable the air conditioning makes it to live inside.
I love that analogy.
So we know how to classify it and stage it, but what is actually causing the pump to break down in these specific ways?
The culprits and phenotypes.
Yeah. If we look at HFrEF, the weak, dilated heart, ischemic cardiomyopathy is the dominant culprit. Roughly 60% of cases stem from a previous myocardial infarction. The blood supply was cut off, the muscle died, and now the pump is weak.
But the non-ischemic causes for HFrEF are incredibly diverse. It isn't always a clogged artery.
Right. The notes mention genetic mutations, too.
Yes, like TTN or LMNA gene mutations. They essentially cause the microscopic sarcomeres, which are the contracting units of the heart muscle, to just unravel and fail. There are also viral or autoimmune issues, like giant cell myocarditis, where the body's own T cells aggressively destroy the heart tissue.
And the toxic causes are wild. Chemotherapy agents like doxorubicin generate massive amounts of free radicals that specifically target cardiac cells.
And we can't ignore recreational substances. Alcohol, cocaine, methamphetamine. They force the heart into such chronic high adrenaline overdrive that the muscle essentially burns out.
Even endocrine disorders like severe hyperthyroidism can cause chronic tachycardia, leading to metabolic exhaustion. The heart is literally working itself to death.
But when we look at HFpEF, the stiff diastolic dysfunction, we don't typically see those acute toxic or viral burnouts.
No, it's a completely different vibe. The most common cause of HFpEF is long-standing hypertension.
Years and years of the heart pumping against immense vascular resistance causes the muscle to thicken, much like a bicep thickens when lifting weights.
Except in the heart, that thickness comes at the cost of flexibility. And aging itself drives increased collagen deposition, making it even stiffer.
Which brings us to the typical HFpEF phenotype. The literature paints a very specific demographic picture here, an elderly female patient who is hypertensive, obese, and diabetic.
The systemic inflammation from obesity and diabetes directly fuels the stiffening of the cardiac tissue. And atrial fibrillation, or AFib, is intricately linked to this phenotype too.
Oh, AFib is devastating for HFpEF patients.
Because their left ventricle is so thick and stiff, right? Passive blood flow just isn't enough to fill it.
Exactly. It relies heavily on the atrial kick, that final coordinated squeeze of the upper chambers to force blood down into the stiff lower chamber.
But when a patient goes into AFib, the atria just quiver chaotically. They lose that kick.
And for an HFpEF patient, losing that 20 to 30% boost in filling volume can send them into acute failure and flash pulmonary edema almost immediately.
Wow. Now, we focused heavily on the left side of the heart failing, both the weak HFrEF and the stiff HFpEF. But the right side of the heart has its own unique failure dynamics.
Yes, and this is where it gets really interesting.
Here's the ultimate exam pearl from the notes. The most common cause of right-sided heart failure is actually left-sided heart failure.
The anatomy of the right ventricle makes it incredibly vulnerable to what is happening on the left side. The right ventricle is just a thin-walled, low-pressure pump designed only to push blood the very short distance into the lungs.
While the left ventricle is the high-pressure powerhouse pumping blood to the whole body. Think of the circulatory system like a massive highway. The left side of the heart is the toll booth, pushing cars out onto the systemic highway.
And if that left-sided toll booth fails, you get a massive pileup.
Exactly.
Yeah.
The blood can't move forward, so it backs up into the pulmonary veins and then into the lungs themselves. Eventually, that severe traffic jam backs up all the way through the pulmonary system and hits the right side of the heart.
Suddenly, this thin-walled, low-pressure right ventricle is trying to push blood into an immovable wall of high-pressure fluid.
And it just isn't built for that resistance. It dilates, gives up, and fails.
The backward pressure simply overwhelms it. Now, there are primary causes of right heart failure independent of the left side. Severe pulmonary issues like COPD or sleep apnea can cause cor pulmonale,
Or an isolated right ventricular heart attack.
True. But mathematically, the left-causing right pathway is by far the most dominant mechanism.
So with all these different mechanisms, genetic breakdown, chemotoxicity, massive pulmonary traffic jams,
Yeah.
how do doctors figure out exactly what state a patient is in when they walk into the ER?
They rely on a specific diagnostic matrix based on hemodynamics. The clinical presentation is evaluated on two primary variables, congestion and low output.
This creates the wet versus cold matrix, right?
Yes. Wet refers to congestion, meaning the fluid is actively backing up. The symptoms here are incredibly visual. Orthopnea is a classic sign.
That's when a patient lies flat and suddenly can't breathe because the fluid shifts into their lungs, right?
Exactly. The gravity-assisted venous return overwhelms the failing left heart. You also see raised jugular venous pressure in the neck, peripheral edema pooling in the legs, and you can actually hear pulmonary crackles with a stethoscope.
And the other variable is cold, which indicates low cardiac output. The forward flow is failing.
The symptoms here include profound fatigue, hypotension, altered mental status because the brain is hypoperfused, and physically cool extremities as the body shunts blood away from the skin.
So based on those two variables, a patient falls into one of four buckets: warm and dry, warm and wet, cold and wet, or cold and dry.
And this categorization dictates immediate life-saving treatment. A warm and wet patient primarily needs potent diuretics to pee out the fluid volume.
But a cold and wet patient is in severe cardiogenic shock. Their pump has failed, and they are drowning. Giving them standard diuretics might drop their blood pressure further and literally kill them.
Right, they need positive inotropes or mechanical support to force the heart to squeeze.
But doctors don't just rely on symptoms. They use biochemical markers in the blood too. The cornerstone biomarkers are the B-type natriuretic peptides, BNP and NT-proBNP.
These tests have a massive negative predictive value, meaning if the numbers are low, you can confidently rule out heart failure as the cause of a patient's shortness of breath.
The physiological mechanism here is just brilliant. When the heart muscle is physically stretched by excessive volume and pressure, it secretes these natriuretic peptides as a distress signal.
The peptides travel to the kidneys and signal them to excrete sodium and water, attempting to lower the blood volume and relieve the stretch.
So for BNP in an acute setting, a value under 100 means heart failure is highly unlikely. A value over 400 means it's very likely. But the NT-proBNP is particularly fascinating because the cutoffs change based on your age.
Yes, age is a huge factor here. If you are under 50 years old, the cutoff to rule out acute heart failure is 450.
Okay, and then it goes up for older patients.
Exactly. If you're between 50 and 75, the cutoff jumps to 900. And if you're over 75, it needs to be under 1800. As we age, our baseline renal function declines and myocardial stiffness naturally increases.
So the background noise of NT-proBNP in the blood is just much higher in a 78-year-old than a 45-year-old.
Precisely.
But there are biological tricksters that can completely skew these readings. Patients can have falsely elevated natriuretic peptides if they have chronic kidney disease, because the kidneys just aren't clearing the protein from the blood.
Sepsis and AFib also cause false elevations, but this raises an important question. What about falsely low readings?
Right. The biggest culprit for a falsely low BNP is obesity.
It is a massive clinical blind spot. The adipose tissue, the fat cells, actually possess receptors that bind and actively clear natriuretic peptides from the bloodstream at an accelerated rate.
So what does this all mean? A morbidly obese patient could be in florid heart failure, actively drowning in fluid, but their lab value comes back looking completely safe.
Yes, because their fat cells are clearing the distress signal before the blood draw can even detect it.
That is terrifying. It proves why over-relying on a single test is dangerous, and why they incorporate a broader panel of biomarkers now, like troponin. We usually associate troponin strictly with acute heart attacks.
But in chronic heart failure, doctors look for persistent low-level elevations of troponin. Even without a blocked artery, the immense chronic wall stress of a failing heart causes microscopic ischemia.
The cells are stretched so tight that their microvascular blood supply is pinched off. And as those individual cells die, they leak troponin.
A persistent elevation tells the physician that the heart is actively taking microscopic damage every single day.
Which carries a much worse prognosis. They also look at ST2 and galectin-3. These aren't stretch markers, they are markers of myocardial fibrosis and inflammation.
They tell the doctor how aggressively the disease is replacing healthy heart muscle with dead, stiff scar tissue.
Okay, as we round out this deep dive, there's some fascinating special cases from Dr. Esfiller's notes that really test these diagnostic rules. scenarios where the standard mechanisms are basically hijacked.
Yes, the outliers.
The first is cardiac amyloidosis. This is an infiltrative disease where abnormal proteins misfold and literally deposit themselves into the heart muscle. It makes the heart incredibly thick and stiff, mimicking standard HFpEF.
But the diagnostic presentation is a complete paradox. An echocardiogram will show intensely thick, bulky left ventricular walls. In a normal hypertensive patient, that generates huge electrical signals on an ECG.
But in an amyloidosis patient, the ECG shows shockingly low voltage.
Because it isn't actually healthy muscle making the wall thick, it's just a wall of dead, electrically silent protein.
Right. You have the paradox of thick walls on ultrasound, but tiny electrical signals on the ECG. And those misfolded amyloid proteins deposit systemically, right? They commonly infiltrate the ligaments in the wrists.
Which compresses the median nerve, so a classic clinical clue is an elderly patient with new onset heart failure and bilateral carpal tunnel syndrome.
Connecting a stiff heart to numbness in both of your wrists feels like an episode of a medical mystery show. But structurally, it's the exact same protein causing both issues.
To confirm it, pathologists use a Congo red stain on biopsy tissue, which produces a highly specific apple-green birefringence under polarized light.
Or they use a targeted bone scan called a TC99-meto-PYP scan that lights up the amyloid deposits in the chest. Another highly specific outlier is peripartum cardiomyopathy.
This is a severe form of HFrEF that develops in the very last month of pregnancy, or up to 5 months postpartum. The mechanism involves profound oxidative stress and the abnormal cleavage of the hormone prolactin,
which suddenly becomes toxic to the heart muscle. The physical strain of the increased blood volume during pregnancy simply breaks the heart. Risk factors include carrying twins, advanced age, and preeclampsia.
But unlike ischemic heart failure, where the tissue is permanently dead, the ejection fraction in peripartum cardiomyopathy actually has a strong chance of recovering completely once the hormonal environment normalizes.
However, the medical guidance is absolute. If the ejection fraction does not recover, future pregnancies are strictly discouraged. The mortality rate of subjecting an already weakened heart to another pregnancy is simply too high.
The final special case isn't a rare anomaly at all. It is a systemic issue found in roughly 50% of all heart failure patients. Profound iron deficiency.
And we aren't necessarily talking about clinical anemia, where the red blood cell count is low. We are talking about the sheer depletion of elemental iron stores within the tissues.
The cardiac myocytes are packed with mitochondria, the energy factories of the cell. Those mitochondria require iron to run the electron transport chain and generate ATP.
So without iron, the engine isn't just mechanically broken, it is completely out of the fundamental biochemical raw materials it needs to spark. That cellular energy crisis directly translates to reduced exercise capacity and more hospitalizations.
The guidelines now mandate that doctors must proactively check ferritin and transfer in saturation in all symptomatic heart failure patients.
Correcting it with intravenous iron replacement can drastically improve a patient's quality of life, even if their ejection fraction never improves.
It really highlights a vital reality of modern cardiology. You simply cannot treat the heart in isolation.
Which leaves us with a fascinating, slightly provocative thought to end on for you listening at home. We've explored how ejection fractions dictate therapy, how structural damage is a one-way street, and how backward pressure destroys the right ventricle.
But we also saw that systemic obesity and diabetes are the primary drivers of the massive HFpEF epidemic.
We saw how fat cells actively hide the disease from blood tests. And we saw how a lack of systemic iron grinds the cellular energy factories to a halt.
So when we look at the modern landscape of this disease,
is heart failure even strictly a disease of the heart anymore? Or, in many cases, is the failing heart actually just the final, loudest alarm bell of a whole body metabolic breakdown? Keep that systemic perspective in mind.